complications. So it will be suitable for most people in the audience, despite them not being neurosurgeons. So we'll start with the many reasons to come to Oaxaca, and great architecture, wonderful food. But the main reason is because it's friendship, and this is Daniel when he looked somewhat different. And Daniel was a resident with us in Tel Aviv for 6 years until graduating and moving on back to the United States and then to Mexico to practice. And it's a great privilege and fun to be able to come here and meet him and give this presentation. So you all know that in medicine we experience frustration, frustration, huh? And this is very typical when we encounter complications. So that's why I wanted to talk about this issue of complications. Uh, in this case, it was about brain tumor surgery, but as I said, it's applicable to many other conditions in medicine. And it's not going to be a typical neurosurgical presentation. It's going to be with some gestalt and general thinking. So when I decided to give this talk, I became a little bit paranoid because I said, why, what are they going to think when I give this talk? Is this because um, I'm a great neurosurgeon? Or maybe it's because I'm very experienced with complications. So it was a dilemma, but I said it's worthwhile to go ahead and give the talk anyway. And the problem with the complications is that we tend in everything in our life to make the same mistake over and over and over again, hoping that something better will come, but it's in our genes to repeat those mistakes. And the whole question of complication and complication avoidance lies in this do and do not do things. And this is something we need to keep in mind. So there are a few lessons. And I think that's the most important one, is that you need to learn from your mistakes. So you need to understand and debate why you have a suboptimal result and investigate in depth the whole process of the decisions that you made in the treatment. You need to look at the steps that you've made surgically or medically, depending on your specialty. You need to acknowledge your mistakes if you've made mistakes and not try to push them aside and, uh, uh, and, and try to ignore them. You need to discuss this in what we call M&M, Morbidity and Mortality Conference. And you need to convey the information of the complications to the family and to the patient. And I know this sounds strange because they always tell you that there are medical legal issues, and if you discuss it with the patient, it may result in litigation. But the fact is that if you're honest with the patient and family, this is less likely to occur. So this is something that we need to remind ourselves. And this is a cartoon that really recognizes this thing. They say, I was going to sue the neurosurgeon, but then he changed my mind. So he could have done this surgically, but mostly it's because there was good conversation with the patient and family. Now, you need to, in this, the M&M conference, the Conferencia sobre Morbididad, Mortalidad, right? Okay, so I will take you to a journal called Journal of Irreproducible Results, or Revista de Resultados Irreproducibles, right? This is a great journal that's unfortunately not published anymore. This is it's a humoristic journal, but it deals with real life scenarios. So this is the journal. And regarding morbidity and mortality conference, they published back in 1985 this great paper, which is called "How to Present an M&M Conference." Okay, and I'll share some of the details with you. So this is the original in English, and I will skip to the Spanish translation. And the first one is put the blame on anesthesia. That's the first thing. As a surgeon, you did the mistake, patient died, said the anesthesiologist is guilty. If this doesn't work, you can blame the patient himself. You said this is a very efficient technique that you say, if the patient wasn't chewing tobacco, then he would have had this complication that needed to amputate his leg and he would have died from infection. So it's not your fault, it's the patient's fault. If this doesn't work, put it on the nurses. The nursing staff did not pay attention, did not treat the patient efficiently, and that's why there was the complication. Now, this is a very efficient technology, especially if you have hospitals affiliated with religious institutions. And you say it was God's will. And despite the maximum attempts, the patient died and is probably better off. And of course, it's not your fault. This was God's will. Very efficient in those cases. And if everything else fails, you need to throw yourself at the mercy of your colleagues. And this is your Spanish translation. You say, I'm really sorry, mea culpa, and they will forgive you for this thing that you've done. The only thing you cannot do is you never blame your superior attending physician. That's never going to be his fault, and you need to keep it in mind. And you need to understand that to make a mistake is human. But if you can blame it on somebody else, this shows managerial potential. It shows that you can really be a very good manager. And it also allows you to be creative, such if you can put the blame on somebody else, some mistake that you've done, but if you find another person to blame, that's going to be very creative and very efficient. But one of the major issues, seriously now, with complication is to try and expect them ahead of time and to do things that will prevent them from happening. And this will be very efficient in preventing many of the complications that we encounter in medical practice. Again, not just surgery, but in everything else. So lesson 2, you need to prepare, and this is for surgeons mostly, you need to prepare for the procedure and the decision that you make on the treatment. And to do that, first of all, you need to acknowledge your competency, your aptitude, because sometimes you take on operations or treatments that you're not well equipped to perform. You don't have the experience, you don't have the technology, and you need to be sincere and say, this is something I cannot do. This is something that I need to refer to somebody else. This is something that I don't have the equipment to do this properly, and not take on any kind of adventures without knowing the potential outcome of the patients. You need to consult with your peers, with other physicians, and pay attention to what they tell you. We all have egos, so we tend to say, yeah, I'm not going to ask for permission or advice for somebody else because I'm better than he or she. But that's a mistake because we are not, gods. We all make mistakes, and we should listen to our colleagues and see if we can learn from time to time what needs to be done. Another important thing is you need to document everything in the notes before you treat the patients. This is not just for medical legal issues. It's because that when you're writing down things, some other issues come to mind. And it reminds you of what needs to be done, needs to be said, or needs to be prepared for surgery. So this is a very important technique that you need to do this consciously on every patient that you treat. And especially, you need to not be afraid to ask for help and assistance. And when you do things that you think that another person's opinion or help will be helpful, again, you need to overcome your ego in those cases. And it's really making analysis about the risk and benefit of what you plan to do, which should come with a good outcome. Uh, Another important thing that Daniel can tell you, I was always telling the residents, always think of the worst possible scenario for what you're doing. You need to look at it and think that there's going to be major catastrophe in everything you do. And if you get this set of mind, then you're ready to do whatever is needed because you've expected the unexpected worst possibility. For example, this is a patient, this is exposed dura after a craniotomy, patients with a brain tumor that has hemorrhaged, bled, and then you open the dura and you can see the whole brain is mushrooming out from the brain. And typically you panic because you can see that this is going to be a major catastrophe. But you can see this mushrooming brain coming out, and you say, oh, this patient is going to die momentarily. But if you expect this, you know what needs to be done, and you deal with the situation correctly. There are many types of complications, and a typical one is incorrect indication. So this is a patient, you can see this is a tumor. It involves both sides of the brain. And a surgeon decided that he's going to operate on this tumor and take it out, which is, of course, stupid, right? You take a patient, you take out all the brain, you may take out the tumor, but you obviously destroy the patient. So this is a wrong decision. Or this very diffuse tumor, you can see in dark gray, involves a major part of very functional areas of the brain. If you take this thing out, you decide to remove it, the patient will be hemiplegic and with major neurological deficits. Another very typical mistake is to use a wrong indication for patients who are not suitable. So if a patient has got very poor performance status, he will never enjoy the operation. He will deteriorate anyway. He has severe systemic diseases like widespread metastases of terminal cancer and very old patients. To make any kind of aggressive surgical decision on this patient will be a mistake. And we need to remember that sometimes there are options for end of life that do not necessitate doing inappropriate and extreme surgical procedures. Another typical example in complication in neurosurgery is not respecting the limits of functional brain areas. So if you go and cause severe, irreversible functional deficits, it will be a mistake that a patient will never enjoy. So there are all sorts of so-called sophisticated imaging studies, functional MRI, DTI, but they're only studies and they really do not always represent the right functional areas, but you need to be aware that causing deficits, neurological deficits of the patient is something that you must avoid at any cost and not looking for a nice MRI after surgery, but looking for a nice functional patient. Very typical complications is not respecting the vascular anatomy. So if you have a tumor that looks like it's involving major vascular functions, in this case, you can see this is the anterior cerebral artery, if you remember the name, and you would expect to see this from the MRI. Then, if you're not careful, you cause stroke, and the patients will have severe deficits. And this is just one example of a large tumor. In this case, it was taken out, but this was post-operative. The patient was paralyzed on the right side. And here, this is called diffusion-weighted MRI that shows brain infarct. You can see the white areas that represent the stroke after surgery that, of course, caused a significant morbidity. We'll skip that. This is an example of a young girl who, this is post, she had a tumor here. This is after resection. MRI shows that she had a stroke and she woke up from surgery actually hemiplegic. She was paralyzed on the left side, but sometimes God is nice to us and the brain can heal itself. And you can see here several months after surgery that she she actually recovered and
keep progressing and everything's doing good. Thank you. Habis shalom.
So this was fortunate, but this was not the rule. So she could have stayed paralyzed, and in this case, she was lucky. Now, veins in the brain are very important, and it took some time to understand that you need to preserve them. If you don't preserve the veins, then you get something we call the venous hemorrhage or venous infarct, like you see in these cases, and some of them may be fatal, and patients may die. It's very important to communicate with the anesthesiologist. This is not something that's always done, and the anesthesiologist should be consulting the surgeon, and the surgeon should be discussing with the anesthesiologist to tell them what's expected in surgery, what's needed during surgery. In some cases, it may be disastrous if there is cases of hypoventilation, for example, which cause increased pressure in the brain. It may lead to significant complication, convulsions during the operation, hypotension or hypertension, and all these things need to be discussed with the anesthesiologist, and it's not two separate team members. They should work really in unison in treating the patients. You need to adapt new technologies, and some of the new technologies may reduce complications and get you better results. These are just some examples. I know that the hospital in Oaxaca have very, very limited resources, and some of them are completely, unacceptable in modern medicine. Not having a surgical microscope for neurosurgery, it's something that's totally, unacceptable. So I don't know the priorities of the hospital, but these things must be dealt with. This is not some luxuries that need to be used. This is the basics of the basics that you need to do to obtain the minimal level of proficiency in treating these patients. So Daniel told me yesterday that you don't have an operating microscope. I thought this is totally unbelievable. It's something that's, in the most remote places in the world, neurosurgeons should have this tool to treat patients properly. So I'm not talking about these advanced technologies that I'm sure that you don't have in Oaxaca, from focused ultrasound and things that I will not even discuss. And I'll skip those things. If you have no microscopes, you probably don't use technologies such as 5-ALA, which shows you uh, using fluorescence, the limits of tumors that need to be resected, uh, and help you navigate through these resections. Um, so, what else? Some of the lessons that we have learned that is that you need after surgery to re-examine everything that was done, and you need to discuss post-operatively, revise the cases, and learn from what was done, so you will learn for the next cases. Uh, what about literature, medical literature? This is, a general topic that it needs voluntary effort by people to read the literature because it takes time. You need to go get it on the internet, go to the library. And there is even a question that the textbooks and books in medicine are becoming obsolete because everything is now available online. So this is a question that needs to be discussed, but it's a very important factor in keeping up with technology, medicine standards, and I will bring you back to this Journal of Irreproducible Results because they also have published what they called the Bennett scale of literature. It's called Keeping Up with the Literature. Okay. Mantenerse al día con la literatura, la escala Bennett. Okay. So this is the Bennett scale. This is the English scale. I will skip to the Spanish translation. So it starts with a student, with medical students, that he can read the complete article, but not understanding any of what it says. Okay, and then it goes to the intern who uses the literature as a cushion because he wants to sleep. And the residents would like to read the literature, but he prefers to eat lunch. And it goes on to the junior attending who can analyze everything because he wants to catch some medical students. And the research assistant who reads everything, makes all the calculations and the statistics again, and checks the references, usually instead of having sex. And it goes back to comparing the medical students who reads everything but doesn't understand anything. But it goes then to the emeritus professor, okay, Professor Emerito, who again reads everything but does not understand anything because of his situation. And that's, by the way, me. I'm an emeritus professor. So I don't know if you're familiar with this book. It's called The Outliers. There's the Spanish translation of this book. It's a wonderful book. Seriously, it shows you how to achieve uh, significant issues, significant things in life. You need to go through a process of uh, doing it over and over again. They give the 10,000 hours as a benchmark for achieving any success in everything, in music, in law, in computers, but also in medicine. And those 10,000 hours that you need to experience before can be translated into 10,000 hours of operations. So, but even if you go through those 10,000 hours of operations, you will still have complications, you will still have mistakes. And that's why you need to continue and find a way to reduce this thing and prevent these complications. But some of the major factors when you do have a complication, stick with the family and patient. Don't yield to this human reflex of denial, and stay and move away from patient and family because you don't like to acknowledge the fact that you have made. So you need to stick with it and consciously uh, uh, and cognitively be with the patient and family. And those things may help you prevent the future complications. There are some new technologies that you should skip. I will skip these things because they're really irrelevant for most of the people. And I think that there's something I call the age or the era of the reason, the age of reason. And it's led by experience. So the more experience you have, the more reason, the more understanding you have. And it's interesting to know that the older you get and the more experience you get, you're becoming more conservative in your decision making and understanding the equilibrium between giving a patient a benefit and harming the patient. And something that may be considered by some as and not being brave enough or not being technical enough is really not true. It's because you understand these limits and you become more conservative with making these decisions. And you need to try and use the best technology available wherever you have to try and minimize the risks to the patients. And most importantly, in every field in medicine, you should find a mentor that you can look up to and learn from, trying to emulate and see how you can get even better than what you've been told. And you know, it's very important to be nice to your superiors and try to make them happy. But that's not enough because you need to completely keep your integrity. And when you have issues that need to be addressed and things that need to be changed, you need to voice them and make them clear that they need to be done. So otherwise, you do lose your integrity and the things that you need to do. And with that, I will finish. And I hope some of these few words may have helped some of you, perhaps in the future. Thank you.
Dr. Zvi, we have many shortcomings in Oaxaca. Dr. Daniel does the best possible work, as does the entire surgical team, with the best intention of achieving the best results. It would have been very interesting to have him at our hospital in a person, but the remodeling work in the area made it impossible. I'm so sorry. I'm going to make an announcement to our attendance before we finish our session, if you allow me, Dr. Zvi.
Yeah, sure.
Bueno, compañeros, en el chat les vertí una breve biografía sobre el doctor Zvi Ram, quien es. Es un renombrado neurocirujano y neurólogo israelí, líder mundial en el tratamiento de tumores cerebrales y enfermedades neurológicas. Ha hecho cirugía mínimamente invasiva, neurocirugía endoscópica, radiocirugía. Ha sido jefe de la División de Neurología y Neurocirugía en el Hospital Ichilov de Tel Aviv y pues es una autoridad internacional. El doctor Daniel Rosenthal hace muchos meses me había contactado con la intención de que el doctor Svi nos acompañara en el hospital, nos diera esta sesión presencial, pero coincidieron lamentablemente las obras de remodelación. Aún así, agradezco que el doctor Svi haya accedido a darnos esta ponencia en Zoom. Su visita era muy importante, pero se atravesaron otras circunstancias. Yo espero que con el doctor Daniel en alguna otra ocasión que el doctor Svi nos visite en México y en Oaxaca, pueda acudir a nuestro hospital. Y todo lo que mencionó en su ponencia, pues yo quiero que se queden con las cosas que logré captar y logré leer en las diapositivas que me gustaron mucho, que hay que aprender de nuestros errores, no tener vergüenza de pedir ayuda, no dudar en pedir ayuda. Y hay que sopesar todas las opciones y prepararse para lo peor en los escenarios, como él menciona, que en sus intervenciones neuroquirúrgicas, pues debe haber todo un gran plan para evitar estas complicaciones. Y pues me gustó eso que mencionó sobre la edad de la razón. y encontrar un mentor y un colega a quien admirar. Entonces, doctor Daniel, si está por ahí, ¿me podría ayudar a agradecer al doctor Svi?
Yeah, thank you very much, Zvika, for your presentation. It has been very nice to listen again to you and to have. I always have your voice inside my mind when I'm taking decisions. I feel like you're talking to me, and then it was very nice to listen to you again, kind of live. Yeah, and I always remember that you're telling if that's real or it's just wishful thinking, the bias of the wishful thinking in the surgeons. And thank you very much for your presentation, your time, and sharing your knowledge with us. I really appreciate it.
Well, thank you for the opportunity, and it's always fun to meet you, Daniel. And let's hope that you will be able to convince them to get you the better infrastructure to do the stuff that you can do. And I know it's very important. I understand the limitations. I understand the difficulties. But some things must have priorities. This is not asking for, very expensive, exquisite things. This is really basics. I know your capabilities. I know that what Daniel can do can be improved tremendously by having this kind of basic requirements that he needs. And I'll be happy to help in any way that you may need assistance in trying to do that, because Oaxaca is I think it's probably the most beautiful place in Mexico. I think this is a place of culture and excellence, and I think that this should be reflected also in the medical care that you have in Oaxaca. And anything you need that I can help, please feel free to do and ask me.
Sure.
And
Thank you.
good luck to all of you. Okay, and thanks again for
Yeah,
the opportunity here.
yeah.
Okay.
Our pleasure. Thank you very much, Rika.
And then a great thank you from the HNO for coming over here, and we invite you to Oaxaca anytime.
Okay, thank
Great
you.
appreciation for you.
Thank you very much. All right.
Bye. Thank you.
Thank
Adios.
you, doctor Svi.
Bye bye.
Adiós.
Bye.
Adiós.
Adios.
Gracias, compañeros, por visitarnos. Gracias, doctor Daniel, por estar interpretando. Vero, Brena, me hubieras avisado que tú sabías inglés, tú me hubieras ayudado a presentar al doctor Svi. Espero que se hayan unido los residentes y los demás compañeros y hayan disfrutado esta sesión que nos hace ver que hay mucho más que lograr en Oaxaca, en nuestro estado. Ha sido intención del doctor Daniel pedir su microscopio, hacer sus cirugías estereotáticas y muchas cosas de ciencia que aún podemos dar más, todos por los niños en Oaxaca. Gracias, doctor Daniel. Le mando
Vale.
muchos saludos y
Igualmente.
felicitaciones.
Vale.
Felices
Hasta luego.
fiestas a todos los compañeros. Posteriormente les haremos llegar su constancia de participación. Gracias por acompañarnos este año de sesiones académicas. Esperemos entrar en el 2026 con muchos conocimientos más y compartiendo muchas experiencias. Gracias, compañeros.